Providing excellent patient care and taking the third party out of medicine is something I am very passionate about. The objectives of my talk are to explain why and how I found my niche and made my direct pay internal medicine practice successful, as well as patients' and physicians' gains and benefits from a direct pay internal medicine practice. Both my father and grandfather were instrumental in getting me interested in medicine in the first place, and then guiding me away from traditional mainstream medicine. My grandfather practiced medicine in rural West Virginia in the 1940s and 50s when there was no infiltration of government or third parties in medicine. He charged $5 for an office visit. If the patient couldn't pay, he received produce or bartered his services for something he or his family needed. Healthcare was affordable and accessible at that time. My father practiced medicine pre and post Medicare invasion, as I like to call it, and he remembers when Medicare auditors began showing up in hospitals. He was alarmed at the decisions being made by an entity that didn't know the patient and also had no medical training. Seeing how the government was taking over medicine, my father did all that he could to discourage me from going into medicine. But genetics triumphed. After several years of cancer research and telling myself I just wanted to remain in the lab, I realized my true interest was in clinical medicine. During my residency and the 1 year I spent in a traditional multi-specialty group practice, I became very frustrated with the number of patients to be seen per day. Frustrated with third-party intervention in life-changing decisions for patients and the terrible care that resulted. I will never forget the time during my first year of practice when I was so behind that I actually told a patient they had cancer while I was standing up and in less than 5 minutes with the entire family in the hospital room. Now, I knew better than that. My upbringing and my training taught me to sit down on the same level as the patient and take more time when delivering this kind of news. But I was extremely behind. The ER was paging me. I was overdue to read stress tests for the hospital. I'm sure everyone in this room knows exactly what I'm talking about. So 9 years ago, I decided to leave the group practice and establish a cash-only fee-for-service practice. This made the most sense to me. It was a practice just like that of my grandfather's before the invasion of Medicare. My overhead is reduced, the middleman mostly removed, and I have attracted patients that care a lot about their health and are looking for a similar-minded physician. I've been a member of AAPS since I was in medical school 15 years ago, and as a result was able to visit with Dr. Jules Madrigal, past president of the AAPS, who at that time had recently started her own direct pay practice in Texas. And she was instrumental in the development of my practice, and I actually patterned my current practice after hers. And here's how I set it up. I found a 1,000 square foot office and renovated the space. I have 3 exam rooms, a nurse's station, reception area, waiting room, kitchenette, and a physician's office. I bought secondhand from a physician that was leaving the area 2 exam tables, an EKG machine, otoscopes, blood pressure cuffs, a scale, chairs, and desks. I chose the EMR that Dr. Madrigal was using, Amazing Charts, with a one-time service fee at that time, as there were no issues with impending ICD-10s. Hence, it wasn't necessary to pay a yearly fee and update my EMR. This was financially quite appealing to me and did the trick for recording. I do still use Amazing Charts now, but I have to pay a yearly fee for upgrading, and I choose to do so since the ICD-10s, I guess, truly appear to be coming soon. We shall see. I bartered with a local lab company to get discounted labs, not quite as cheap as Josh's, but pretty cheap, and I passed the savings on to the patient. My CBC is $4, my CMP is $8, and my cholesterol is 12. So I contacted insurance companies that I had previously been a participating provider for to notify them that I was no longer participating with them. I opted out of Medicare and continued to do so every 2 years as required by HHS. I researched local prices for CPT codes, set my prices to be competitive with others, and I began. At first, my husband was my receptionist and computer technician. I now have a full-time receptionist and a full-time medical assistant. My husband, much to his chagrin, is still my computer technician, mostly because he's so good at it. and I broke even by the end of the first year. I did encounter difficulties, of course. So this was 9 years ago. What I did was very uncommon at that time, and many of my colleagues were shocked that I didn't take insurance. One specifically told me it was my duty as a physician to take care of all in need, especially Medicare patients, regardless of financial compensation, quoting the Hippocratic Oath to me. I became known in town as that physician that didn't take insurance, and only wealthy people could see me, which is not true. Quite the contrary, like my grandfather, I will trade services or give discounts to those in need because my practice is free from third-party interference. Call coverage was another problem for me because everyone else in my area took insurance. But I found 2 excellent physicians. We worked out a situation where I see their sick patients when they are out for $75, and they see my patients and bill their insurance for compensation when I am out. Besides AAPS, there were very few resources available at that time to help guide me on how to opt out of Medicare. Andrew Schlafly, who spoke earlier today, graciously helped me answer many, many questions. Thank you. And at that time, there was certainly no information on the HHS website. Even the address to where to mail the paperwork was a mystery. There definitely was no confirmation that it was successful, and it always made me nervous. But as more and more physicians opt out, this process has become more official. And one can find information about this on their website now, and you do get confirmation. I did want to add, though, that this year I got a little overzealous, and I decided to opt out in October instead of November. Did the whole thing, return receipt requested, and I got a phone call to my office in the middle of November and said I had sent it in too soon, and I had to redo the whole thing and send it in no earlier than December 1st, recertify it, resend it. So don't get overzealous with the government, I've decided. And if you're seeing TRICARE patients, I guess be diligent, research the rules on how to opt out. To be honest, those rules were, to me, were trickier than actually Medicare's rules were. So I still have some headaches with insurance. I give each patient an ICD-9 CPT-coded receipt that they can submit to get reimbursed by their insurance, with the exception, of course, of Medicare patients. I still have to prior auth scans and studies as well as medicines. And I have been astounded by the increased need to prior auth $4 generic medications since the start of the Affordable Care Act. Fortunately, I have more time for this than the average insurance accepting physician. But a lot of times I'll just call my patient and tell them that they should just go pay and get the $4 medicine. And just cut out the middleman again. At the start, I briefly placed ads in the local newspaper. This actually got me some new patients, but most of them were drug seeking. I persisted, and eventually most of my referrals came from word of mouth, family and friends of current patients and other physicians in town. I was invited to give a few community talks. Several local physicians became interested in cash-only practice and consulted me for advice. Several local newspapers did articles on me, and I had several radio talk show interviews, one of which I had the pleasure of being interviewed with Dr. Amerling. So eventually I got an interview on NPR, and it actually generated a lot of calls and emails to my office from all over the country. Having more time and freedom allowed me to dedicate more time to patients and their issues. I developed a handful of instrumental relationships with excellent referral physicians in my town, as well as the nearby DC, Baltimore, and Charlottesville area. This led to quicker, better referrals to competent specialists. And this is one reason that a lot of patients in town will transfer their care to me from another physician. So again, I have now been doing this direct pay internal medicine practice for 9 years. I am usually fairly booked up 2 months in advance, although I always leave room to fit in a same-day sick visit, so I take better care of my patients. You may be surprised to know that more than 50% of my patients are Medicare patients. I make a decent salary, not as much as if I was owned by the hospital, but then again, I would be a slave to the hospital and their standards of care. I spend a great deal of time with my patients, 1.5 hours with a new patient, 45 minutes to an hour for return, and this allows me as a physician to better diagnose patient issues, as well as get to know my patients better. I have diagnosed things in new patients or my own patients that other physicians have missed, mostly because I have more time to take a better history. One sick patient had been worked up in the ER, was sent home, followed up with his cardiologist the next day, sent home again without a diagnosis. I saw him 2 days later and discovered he had endocarditis. He had had a change in his murmur, and also after lengthy questioning, I realized the patient did not understand the definition of chills. He had apparently been sweating so much that he would change his night clothes every hour. I have more thoroughly worked up anemias revealing cancers. I even diagnosed a renal cell cancer that was missed by both the patient's urologist and the urological oncologist. The patient's urologist apparently had ordered a CAT scan without contrast. And when I called the oncologist, he didn't realize that the CAT scan didn't have contrast, as it was from an outside facility. So we got the right contrast CT ordered, and he ended up having a renal cell cancer in the ureter. So the patient's now without a right kidney, but alive and well with no recurrence and didn't need chemotherapy. Again, I had more time to review studies and records. I do have a reputation in my community for sending very thoroughly worked up patients, and many specialists in the community don't require me to send records over to be reviewed prior to actually scheduling the appointment, and that's sort of standard in my area, but it quickens the referral process and results in better care. My direct pay practice has been rewarding to me, as I have been able to successfully address patients' problems and give them the best care. It allows me adequate time for a new patient workup and extra time, if needed, on complicated return patients. I know my patients extremely well, and my practice allows for an excellent lifelong relationship and excellent care. I have more time to communicate and network. I have been able to develop relationships with excellent specialists, hence my patients almost always get special treatment and quicker care. My daily patient load is 8 to 10 patients, compared to close to 40 patients at the multi-specialty group where I used to practice. I have time to travel internationally and practice medicine in developing countries at least once a year, in which I am particularly interested. I feel like doing this helps me fine-tune my physical exam skills and my resourcefulness. Practicing medicine in a developing country takes me back to the days of when my grandfather and my father practiced medicine. Doing this not only helps me be a better physician, but also helps those in need. During my medical school years, I met many patients who were cared for by my grandfather and my father in rural West Virginia, and they fondly remember the great personal care they received. And I am proud to be continuing the tradition of providing affordable, accessible, excellent care. For all the aforementioned reasons, I sleep better at night. And I'd like to end with my favorite quote from Sir William Osler: "The good physician treats the disease. The great physician treats the patient who has the disease." And you can learn more about my history and my practice, as well as listen to my interviews at my website. I love that one. Thank you.